Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be doing a quick discussion of the questions which I have posted as a quiz on 28th of April on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I'm posting 5 questions and following day I'm also giving the explanation of those questions. So please follow my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So the first question is, all of the following are the features of the juvenile myoclonic epilepsy except myoclonus on awakening, generalized tonic-clonic seizures, automatism, consciousness is preserved. So the feature which is not present in juvenile myoclonic epilepsy is the automatism. So if you take this automatism, it is the feature which is present in complex partial seizures, but it is not present in the juvenile myoclonic epilepsy. Now, in juvenile myoclonic epilepsy, there will be myoclonus on awakening, and the other important type of seizure is generalized tonic-clonic seizure. And you have to remember that the consciousness of the individual is preserved in case of the juvenile myoclonic epilepsy. Now, let me tell you some of the important points about juvenile myoclonic epilepsy. It is the one which affects mainly the adolescent age group. And these myoclonic jerks, they are most commonly seen in the morning after awakening. And if the individual does not have an appropriate sleep, the episodes, they get precipitated. And these myoclonic jerks, they are usually bilateral myoclonic jerks. And apart from myoclonic jerks, these individuals, 90% of these patients, they develop GTCS, generalized tonic-clonic seizures. And these patients, they also have the family history of the epilepsy. And how will you diagnose this juvenile myoclonic epilepsy is by your EEG. EEG shows 4 to 6 Hz irregular polyspike activity. And what is the drug of choice for juvenile myoclonic epilepsy? That is the valproate. So this is about the treatment of juvenile myoclonic epilepsy. In short, about juvenile myoclonic epilepsy. Now, you see the next question. All of the following drugs are used for managing status epilepticus except. The options are pregabalin, then topiramate, then thiopentone sodium, and then carbamazepine. So let me tell you that carbamazepine, it is not used in the treatment of the status epilepticus. Carbamazepine, it is a drug of choice for the focal epilepsy, but it is not used in case of the status epilepticus. Now let me tell you the new guidelines which are being followed for the treatment of the status epilepticus. See, how is the status epilepticus being classified is depending upon the duration. So it is called as impending and early status epilepticus if the duration is around 5 to 30 minutes. And if the duration of the status epilepticus is in between 30 minutes to 48 hours, then we call it as the established and early refractory status epilepticus. And if the duration of the status epilepticus is beyond 48 hours, we call it as the late refractory status epilepticus. Now, in case of the early status epilepticus, right, the drug of choice will be intravenous benzodiazepine. Either we give LZP. LZP stands for lorazepam, or we give midazolam, or we give clonazepam. So this lorazepam is considered as the drug of choice, and the dosage you need to know, that is 0.1 milligrams per kg body weight. So you have to give one dose of the lorazepam and you have to wait for 5 minutes. If the episode repeats, then you can give the second dose of the lorazepam. If the individual is refractory to benzodiazepines in the early status epilepticus, then the alternative drug will be phenytoin 20 milligrams per kg, or valproic acid 20 to 30 milligrams per kg, or levetiracetam 20 to 30 milligrams per kg. So this is up to like impending and early status epilepticus. Now, if the epilepsy is like continuing beyond 30 minutes, we call it as established and early refractory status epilepticus. This again we classify it into two, that is generalized convulsive or subtle status epilepticus, or the other one is focal complex myoclonic or the absent status epilepticus. So if it is in case of the generalized convulsive or subtle status epilepticus, in established and early refractory epilepsy, the drug that you need to give is intravenous midazolam, or the other drug that you can give is the IV propofol. So these are either of these two drugs can be given. If the individual is refractory to midazolam or your propofol, then the other drug is PTB. PTB stands for phenobarbital. So these are the drugs that you need to give in case of the established and early refractory status epilepticus. Whereas in case of focal, that is complex, myoclonus or the absent status epilepticus, the further management is you need to give IV or per oral valproic acid, levetiracetam, lacosamide, topiramate, pregabalin, or the other drugs can be given. Right now, in case of the epilepsy continuing beyond 48 hours, we call it as late refractory status epilepticus. So there we need to give anesthetic agents, right? What are those anesthetic agents? Isoflurane, desflurane, or ketamine. And apart from these anesthetic agents, the other medications that can be given is the lidocaine, verapamil, magnesium sulfate, ketogenic diet, immunomodulation. Apart from medications, what are the other appropriate procedures that can be done? The other appropriate procedures that can be done is surgery. VNS stands for the vagal nerve stimulation. Then RTMS. This RTMS stands for repetitive transcranial magnetic stimulation. That is called RTMS. ECT stands for electroconvulsive therapy or hypothermia. So this is how you should have the approach of the status epilepticus. So the drug that we don't give in case of the status epilepticus is the carbamazepine, is that we don't give in case of status epilepticus. Now you see the next question in the quiz, right? So this is a repetition of the previous question itself. The first line of treatment for status epilepticus is ethosuximide, sodium valproate, lamotrigine, lorazepam. So lorazepam is considered as the drug of choice. That is a first line treatment for the status epilepticus. Now you see the next question. Which among the following is not the risk for the seizures? The options are hypocalcemia, hypomagnesemia, hypokalemia, chronic renal failure. Remember, the electrolyte abnormalities which are responsible for the development of seizures are: number one, your hypocalcemia will cause seizures, hypomagnesemia will also cause seizures, and even hyponatremia will also cause seizures, and even hypophosphatemia will also cause seizures. But remember, hypokalemia does not cause seizures. And apart from this, what are the other metabolic disturbances where you can have the development of seizures is even chronic renal failure and as well as the hepatic failure. Even they are also the risk factors for the development of the seizures. Okay. And apart from that, the abnormalities related to the glucose, that is either hypoglycemia or the hyperglycemia, right? Hypoglycemia or the hyperglycemia. Both of them are the risk factors for the development of the seizures. So remember, hypokalemia, it will affect the heart. It does not affect the brain. Hypokalemia will cause tachyarrhythmias, right? It will affect the heart but not the brain. So the answer is hypokalemia in this question. The last question in the quiz is, which among the following can be used in patients presenting with complex partial seizures known to have chronic liver disease, cirrhosis, and portal hypertension? The options are phenytoin, levetiracetam, valproate, and lamotrigine. So you should give that particular drug which is not hepatotoxic. So among the options which has been given to you, that is levetiracetam, it is not hepatotoxic. The remaining all, phenytoin, valproate, and lamotrigine, they appear to be hepatotoxic. So they have to be avoided. Whereas levetiracetam, if you see, it is excreted through the kidney. So that is the reason why you have to adjust the dose of the levetiracetam according to the renal function. That is, according to the creatinine clearance, you have to adjust the dosage of the levetiracetam. Whereas it is not hepatotoxic. So in case of chronic liver disease, cirrhosis of liver, and portal hypertension, levetiracetam can be given comfortably. So this is about the discussion of the questions related to quiz, which is posted on 28th of April on my Telegram channel. So please do follow my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, and you can follow me on my Instagram handle, that is Rajesh Gubba, for daily updates related to general medicine. Thank you very much and see you tomorrow again for the